guys.
Good morning, morning.
Sorry for the delay. We've had some AV issues apparently, but Paul has very impressively fixed those quickly. So I think everybody in here knows me almost. I'm Angie Bowen. I'm the regional coordinator for EMS for Children and the trauma coordinator at Children's Hospital. Also work as paramedic in Jefferson County. So we're going to talk about kids for the next few hours. We'll get you guys 4 hours of credit for being here. Everybody's on the roster, and thus far I can read everyone's name. So that's good. I'll make y'all certificates and get them back to Paul with this. Any questions before we get started? Okay. Let's talk about Peds. So who likes taking care of kids in the field in here? No, nobody? Sarah. Travis, are you raising your hand, Travis? Okay. A few people, most people hate it because you don't see them very often, right? I mean, in Tennessee, only about 10% of our pre-hospital calls are pediatric and a fraction of a percent are critical pediatric. So it's not you don't know how to do it, it's that it's not second nature like it is with your big kids, right? And, you know, kids come with a lot of psychological baggage. You have terrified parents. You have the fact that it's a child and you want them to be okay. So let's talk about a few tips and tricks this morning to take care of these kids. I'm going to have to. All right, Paul.
It was working.
I know, it worked fine just a second ago. It's still on. Am I just in the...
I heard that back there.
It's what you thought you heard.
Talking about my big head.
I'll just manually do it.
All right. Thanks. All right. So how many times do you get a call for a fever? You get these calls? Yeah. My kid has a fever and everybody gets freaked out. What are some of the old wives' tales that you hear about fevers? What do parents tell you?
Put them in cold water.
Burn it out.
Yeah. Okay. You either put them in cold water or you've got to sweat it out of them, right? What else?
Took your clothes off.
Take your clothes off and not. People have a fever phobia. Is a fever in and of itself a big deal? No. In and of itself, it's not a big deal. Usually what I tell parents is, your child has an infection, your body's doing what it's, their child's body's doing what it's supposed to do to fight off that infection, and it's working harder. When it's working harder to fight the infection, it's going to get hotter, right? I drove my car here this morning. My car is warm because it's working harder, but there's nothing wrong with my car. It's the same concept. So getting parents over that fever phobia is part of our jobs. If you ever walked in and you see a patient, the parents say they have a fever and they're bundled up like Ralphie's little brother in A Christmas Story. They're in this snowsuit and they can't even move. And the parents say they have a fever and yeah, I'm sure they do, because if they didn't when you put, before you put them in there, they certainly do now. So it's just the body's normal response. We're more worried about how a patient looks, right? We had a run of kids come into ER, this was a couple of winters ago, but all of these kids had temps of like 105, 106. Pretty impressive numbers. Not a one of them were very sick. They look like they didn't feel good, but they didn't look as sick as I would expect with a fever that high. So it's not, just like with anything with your patient, it's not the number, it's not what you're seeing on your machine, it's how your patient looks. We do worry about neonates with fever. How come? What's the issue with neonates with fever? You guys are going to have to talk or it's going to be a very long morning. What do you know about neonates? How's their immune system?
Very weak.
Very weak, right? If mommy's breastfeeding, they might get some immunity from mommy, but it takes them a couple of months to really build that up. What else do you know about neonates and fever? Do you see fever in neonates very often?
No.
No. Why? It's not because they're not sick.
Is it because their immune system's still weak?
You're on the right track. It's because they can't raise their temperature necessarily. Your hypothalamus in your brain, right, is your thermostat, and it helps regulate your temperature. Well, in neonates, their hypothalamus is not very well developed. So if they get sick and they're working hard, actually what you'll find is eventually their temperature drops. They're not able to raise their temperature in fighting the infection. It actually gets low. So if you have a newborn within a month or two of being born, and just because they don't have a fever doesn't mean they're not sick. They actually may be a little bit cold. And what do we know about cold patients? Of any age? Poor perfusion. Are they tough to resuscitate? Absolutely. Cold patients tend toward a metabolic acidosis and they're tough to resuscitate. So neonates really are a very concerning population. We deal with sepsis because they're more prone to being infected. They don't fight it as well. They've often picked up something from mommy during the birth process or in the hospital during the birth process. And then they get cold and they're tough to resuscitate. So those kids with a fever or lack thereof are concerning. And then immunocompromised patients with a fever, right? Any patient who's has had chemo, we worry about that. Fever greater than 105, we worry about a little bit just because they tend to be sicker. The higher those temperatures when they get in here, they tend to have pretty severe bacterial infections. But I'm a whole lot more concerned about that kid with a temp of 100 who's lying listless on my cot than the kid with a temp of 105 who wants in all the cabinets in the back of my truck. Hey, it works. All right, rashes. You see a lot of rashes? When do we worry about rashes? Not necessarily on their face. Kids get rashes on their face all the time.
They don't blanch.
If they don't blanch, yes. That's right. So rashes that are itchy are good. We like itchy rashes. And in the ER, I always say mash the rash. If you mash on the rash and it doesn't blanch, you have a problem. Because rashes that don't blanch tend to be things like petechia and purpura. So everybody know what petechia and purpura are? These little pinpoint dots, right here. These little pinpoint dots are petechia, and when you get a bunch of petechia and they run together, those are purpura. What causes this to happen? Why do we see this kind of rash? Anybody know? So this is your blood vessel. Let's say you've got an infection. You've got this bacterial infection, and there's bacteria floating around in your bloodstream. Everybody with me? Well, this bacteria is releasing toxins. Those toxins from the bacteria are eating little bitty holes in the blood vessel, and they're leaking blood. So you get these little dots on the skin. When it leaks a lot of blood, you get bigger dots. So what do septic patients need? How would we treat them?
Fluids.
Fluids, oxygen to start with, right? And then fluids, what kind of fluids? What do you give any shocky patient? Saline. So you're pouring normal saline in here, right? You're giving fluid pulse, which is what you should do. Where's some of that fluid going to go? Out those holes. All right, you firefighters know this. You've got a hole in your hose that's going to leak out. So we're pouring in normal saline, which is what we should do. How many cc's per kilo on a child? 20. 20 cc's per kilo. How fast are you giving that to your shocky patient? As fast as it'll go, just like your adults. If they're shocky, you're pouring it in there. So we're pouring in saline. Some of it's leaking out. So if they don't start to get better, you give a couple of fluid boluses of saline and they don't start to get better, for the paramedics in the room, what do they need? Paramedics? Who are my medics? Raise your hand. Oh, come on, there's more than that. What do you give them? What do you give them? No idea. Anybody? So think about this from a mechanical standpoint. If you've got something leaking, let's say I've got a cut on my arm and it's leaking, what do? You put pressure on it, right? What's going to put pressure on that vein or vessel? Pressors, dopamine. So these septic kids, when you give a couple of fluid boluses and they're not getting much better, they need a dopamine drip. So here's your next step, paramedics, what's your dose of dopamine in kids? Okay, let's try this. What's your dose of dopamine in adults? Do you guys truly have no idea?
2 to 10 months.
2 to 10. In the hospital, we're going to do 2 to 20, but I'll take 2 to 10 mics per kilo per minute. Guess what your dose in kids is? 2 to 10 mics per kilo per minute. You're not going to get really good squeeze until you get up around 10. 2 is just kind of spitting in the ocean. 5 is going to increase your renal perfusion, but you're not going to get good squeeze until you get up around 10. So,
Angie, what would you say is the jump off point for that? When do you, I don't want to say panic and do that? That's pretty much,
when their pressure's low, and we're going to look at normal pressures in a minute. So when you get to that, everybody takes pals. When you get to that hypotensive shock stage or you're headed that way, that's when I would start pressing. Because what's happening here in these areas that they've got these little pinpoint dots, or when you get the big purpura, these children are not perfusing those areas. So not unusual. Do I need to stand somewhere else for that time? When they're not perfusing these areas, they'll lose arms, legs, noses, parts of their face. If they're not perfusing it and it goes long enough, that tissue gets necrotic and they wind up losing it. So not only do you have the potential to have a child who dies, you have the potential to have a child who goes through their life without arms or legs or some other area that you've let not perfuse. So those are the rashes we worry about. Paul, flip that for me, please. It's not working. Okay, so here is what I'm talking about. That is, we've still got a little petechia right here, but this is purpura. And these kids are sick. And this is something that we see. I mean, I bet we have, I don't know, 6, 8, 10 of these kids a year that come through our ER. So it's not unlikely that you will encounter one of these kids at some point in time in your career. And this progresses very quickly. So to give you an example, we had a little girl, this was years ago, but she still sticks with me. She was 18 months old. She had gone to her regular doctor that morning about 10 o'clock and been diagnosed with an ear infection. And they put her on antibiotics, sent her home. Well, about 2 o'clock, Mommy shows up in the local ER and she said she's not any better. Well, everybody went, okay, she's had, 4 hours worth of antibiotics, of course she's not any better. And she said, they said triage her, they sit her in the lobby. She looks pretty okay. It takes about an hour for the doctor to see her. So now it's 3 in the afternoon. The doctor sees her. She started to develop a little pinpoint rash like this. Not bad. He recognizes what it is. He flies her to us. So about probably 4:30, 5 o'clock in the afternoon, she rolls in our ER and she looks like this. So from 10 in the morning, looking okay, getting amoxicillin for an ear infection at the doctor's office, to 5 in the afternoon, she looks like this. This little girl stayed in our unit for probably almost 2 months. She did lose both legs, one of her arms, and her nasal septum. And is probably in her 20s now. So everybody did what they were supposed to, but I know this is one of those low frequency, high risk events that you guys in EMS, especially the paramedics, have to do, but you've got to be able to hang that drip. got to be able to calculate that and fix it. And if you're uncomfortable calculating, call medical control. We'll help you figure it out. But that would have made a difference to her. And then, of course, we've got to get antibiotics on board. So, all right. Respiratory concerns. It's respiratory season, right? So here's what everybody confuses. Strutter versus wheezing. We get in codes from ambulance services all the time, and they say, this patient's wheezing, and when we get there, when they roll through the door, they're actually strutters. And the treatment's very different. So is strutter an upper airway or a lower airway issue? Upper. Does strutter happen on inspiration or expiration? Inspiration. It's that noise that they make, right? So for what reasons do we see strutter? What disease processes? Croup, epiglottitis, foreign body airway obstruction, right? Those are your big three, really. Croup, epiglottitis, foreign body airway obstruction. What about wheezing? Is that an upper airway or a lower airway issue? Lower. And what's your classic disease process that you see wheezing? Asthma. Does wheezing, when it starts, does it happen on inspiration or expiration? Expiration. So if you find it hard to listen to your pediatric patient, and sometimes that's tough because you're listening to a chest this big, right? And it's tough that you're going, where's this noise coming from? If you're listening to a chest this big and you can't tell if it's on inspiration, it's probably upper airway. If it's on expiration, it's probably lower airway. So what do you use to treat upper airway issues? Racemic epi. You guys are carrying racemic, I assume. Yeah. What do you use to treat lower airway issues? Albuterol. Does albuterol work up here? No, it doesn't. So, if you can't tell where it's coming from and you think they're wheezing, and we do get these kids who come in all the time, and EMS says, we gave them, 2 or 3 albuterols and they're not any better. Well, they're not any better because the problem is up here. They're given the wrong drug. So albuterol helps just minimally because you get humidified oxygen in them, but you could do the same thing with saline. There's no sense giving them albuterol. Reactive airway disease, our other term for asthma. What about bronchiolitis? What's that? What's bronchiolitis, guys? It's swelling of the bronchioles. It's a simple one. What usually causes bronchiolitis? What virus or bacteria that we see this time of year? RSV, respiratory syncytial virus. So you guys are kids. Have they had RSV? No. Some have, some haven't. They're little snot factories, aren't they? They snot and snot and snot and snot. So bronchiolitis is the upper part of the lower airway. The best thing to do for bronchiolitis is suction them. Suction, 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 suction. People are afraid to suction kids because they're concerned they're going to make them vagal, right? Or they're gonna hurt something in there. Don't be afraid to suction them. For about 10 seconds at a time, give them a break, suction them again. And then pneumonia. One of the hallmark complaints with pneumonia in kids that we see is they complain of chest pain. If kids walk in the ER and they're 6 and the parents say, I think they're having a heart attack. I go, no, I don't think so. But they're having chest pain. And what has happened is they either have a pleurisy or they have cough so hard they have a costochondritis. They've pulled a muscle between their ribs. So if you hear of a younger child with chest pain, that's one of the first things I think of is it a pneumonia? Questions on that? All right, Paul. Look it for me. Oops. Well, then we both. Okay, there we go. This shows up weird in your program. Yeah. I mean, like the. Okay, so dehydration. So we said we're going to give kids 20 cc's per kilo of fluid. How much fluid do kids have in their body to start with? How much blood volume do they have? Anybody know? So children have an 80 cc per kilo circulating blood volume. So in this bottle of water, there's 500 cc's of fluid, so about a 7-kilo kid, which is what, about 15 pounds-ish? Can everybody picture a 15-pound kid? This is all the circulating blood volume they have. That's it. So is it a big deal if they have some bleeding? Yeah. Is it a big deal if they have some vomiting and diarrhea?
Oh, yeah.
Absolutely. And you know, kids get head injuries a lot, right? They fall and they boink their head, you've got a little laceration, but head likes to bleed and bleed and bleed. Yeah, very vascular area. Can they bleed out? If this is all you got, can you bleed out from a head wound? Absolutely. So keep that in mind. And if we are giving them 20 cc's per kilo fluid bolus and they have an 80 cc per kilo circulating blood volume, and you give 2 fluid boluses, just bear with me for a second. You got a trauma patient, give them 2 fluid boluses. Not unusual, right? What have you done? Very simplistically, what have you done to their circulating blood volume?
Replace that.
Yeah, you made Kool-Aid. You've replaced half of it with salt water that doesn't have hemoglobin, doesn't have oxygen carrying capacity. So with your trauma patients, when you get to that second bolus or so and they're not doing better, what do they need? Blood. Yeah, they need blood. So kids are also at risk for dehydration because they have insensible fluid loss. So that's just, you know, what you're breathing out and the moisture that's just coming off our skin all the time. Kids have a greater skin surface to body weight ratio, right? More skin per their body weight than we do. They have those big heads. They breathe faster. So they're going to have greater insensible fluid loss. They don't renally compensate very well. So their kidneys cannot hold on to fluid like ours do. So have you ever, let's say it's the middle of July and you've been outside working, you know, for several hours and you go in and you go to the bathroom and you pee salt crystals, right? It's very concentrated urine. Little ones can't do that. They're at least 2 years of age before their kidneys get pretty mature. So they will just pee it out. Their body really can't hold on to it. So they will get more dehydrated easier. So those are things to remember when you're dealing with volume issues in kids. Kids are very prone to a couple of things. Gastroenteritis, what does that mean? It's a GI bug. I mean, it's just kind of a general GI bug. It's the diagnosis on a lot of kids at our place. What about rotavirus? Anybody's kids ever had roto? Taking care of any kids with roto? What do you need to know about roto? Probably one of the most things you need to know about roto is it's exceptionally contagious. So, you know, you're told clean your truck, right? Do we always do a good job of cleaning our trucks? Depends on the day, maybe. With roto, you've really got to clean up your truck because just a microscopic drop of this stuff will make you sick. You will go home and you too will have vomiting and diarrhea. Roto has a season. It tends to hit in March. So somewhere in that late February into early April, we see roto, and it stinks. Worse than just about anything, it stinks. Roto is very distinctive. You can walk in the door of the house and go, I know what's wrong with this child, they have roto. So how sick they are really just depends on the circumstances. Some of these kids are, you know, they look okay, they need a little bit of fluid, something to manage their vomiting, and they're fine. Some of them are almost dead, so they dehydrate very, very quickly. Glucose. So y'all have heard this in every class you've taken on kids. Their metabolic rate is twice that of an adult, right? They're burning up twice the sugar and twice the oxygen that we burn up as adults. Very high metabolic rate. And they don't store glucose and glycogen like we do, right? They have very limited stores in their liver. They have very limited stores in their muscles. So when children drop their glucose, they don't have much of a reserve to pull from. Does that make sense? So they drop their glucose pretty quickly. What do we give kids if we need to replace their glucose? D25. What's your dose? I know all of y'all can't see this. What's your dose of D25? How do you know? If you didn't know your dose of D25 in a kid, how do you find out? What tools do you have? Okay, you have Broslow. How does Broslow give you the dose of D25? Do it. It is color coded, but if you looked at your Broslow and found that D25, it's going to tell you how many what? It's going to tell you how many grams. It's not going to tell you how many milliliters. It's not going to tell you how much. It's going to give it to you in grams. So you're going to have to do the math, switch from grams to milliliters. And this is where a lot of people make their mistakes. This is where we see huge drug errors in kids, is the conversion from milligrams or grams to milliliters. You know, the what do I actually drop and give? So for D25, to me, volume's always easier. It's 2 to 4 milliliters per kilo. That's your normal dose. That's easier to remember. For D50, in your bigger people, it's 1 to 2 milliliters per kilo. So, are we given the same amount of sugar here? Yeah, you are. It's half the concentration, but it's double the volume. It's the same amount of sugar. So, if we're given the same amount of sugar, why are we giving D25 to kids? It's more diluted, and that means what?
It's easier for the process.
Well, it's easier for them to process. It's an osmotic issue. That D25, that lesser concentration, is going to be much easier absorbed than the D50. Plus, you have your just practical standpoint of if you've ever tried to push D50 through a 22 or 24 gauge IV, it's tough to do, right? So, what about newborns? Do you give newborns D25? D10. And do we carry D10? No. So what do? Yeah, you take your D25 and dilute it in half, squirt out half of it, and draw it up, and you've got D12 and a half, and that's close enough. So guess what the dose of D10 is? 4 to 6 milliliters per kilo. Yeah. So we talk about kids. We give this to kids. What age? When do you use D25? When do you use D50? Well, if they fall off the Broslow tape, is that where you're going with that? Yeah. If they're too big for the Broslow, actually, it's a younger age group. Depends on whose text you read, American Academy of Pediatrics or American Heart or who you read. But some people say 2, some say 4. Our guideline, and if you called in, we're going to tell you if they've started school, give them D50. If they haven't started school, give them D25. It's a very technical cutoff. But that was very simple. And that's what our medical director of the ER said. You know, just tell EMS, if they haven't started school, D25. Don't worry about those age ranges. So that's a little easier. Right here, we place blood glucose when it's less than 50 or the child's symptomatic. Younger children will tolerate a lower blood glucose. I've seen babies in our nursery, their glucose gets down to 25 or 30 before they get really jittery. If our glucose was 25 or 30, we'd be passed out, right? So little ones will tolerate a lower level. So that's not unusual. While we're talking about glucose, let's talk about DKA for a minute. We see a lot of children they're kind of older school age, young teenagers, so maybe 8 to 12-ish, who are new onset of DKA. They are that classic altered level of consciousness, Kussmaul respirations. You'll get that they've been thirsty, they've been peeing a lot. On your glucometer, it's probably gonna read high. But a lot of these kids have a glucose of 800, 900, or 1,000, or even I've seen 12, 1,300 in these kids. It's excessively high. Well, if they go, and this is, and Sarah May can speak to this too, if you are doing an inter-facility transport, what you need to be making sure of is this glucose is not dropping too quickly. Because in outlying hospitals, who primarily deal with adults, they see a glucose of 1,200 in a kid and they freak out and they want it down. Down, down, down. And they want it down quickly. And they start hanging insulin. Well, if you drop it more than about 100 points an hour, that child will wind up with cerebral edema, usually either long-term disabilities or they will die. And we have had way too many, one is too many cases, but we've had way too many of these. And it's, it's not EMS per se because we're not hanging the insulin, the hospitals are, but if you're transporting, actually what I would prefer you do, what our hospital would prefer you do is call medical control at Children's and say, can I turn this off? Because it drops way too quickly and it's worse for these kids than managing down slowly. We've always said in EMS, well, we can't do anything about this high blood sugar because we're not carrying insulin. Well, a fluid bolus will drop their insulin about 10%. So if you're just giving them a saline bolus, right, solution to pollution solution, if you are just giving them a saline bolus of 20 cc's per kilo, their glucose is going to drop about 10%, and you have started them on the right pathway. So be very, very careful if you're transporting really any patient who has an insulin drip going. All right. What about kids who are just not acting right? You get those calls? I don't really know what's wrong with my kid. They're just not acting right. Have you guys seen this AEIOU tips? Like, I think I learned this in EMT school or somewhere along the way. But it's not an end-all and be-all, but it helps you rule out some things. Is it alcohol ingestion? Did mommy and daddy have a party last night and the child has drank, part of the vodka that's left over that's sitting on the coffee table? Is it epilepsy? How many people last spring saw my seizure lecture? Just a few. Kids have very subtle seizures and they get missed. So, if they're not acting right, maybe it's a seizure. Keep that in your head, even if it's just a hand twitching or an eye twitching. It's not always generalized clonic-tonic activity. Is it an insulin issue? So what we've just talked about. Is it an overdose? Have they gotten into somebody's pills? One of the most common ingestions I think we get are beta blockers. These kids get into parents or grandparents' beta blockers, and then they can't get their pressure up. Their pressure bottoms out, their heart rate bottoms out, and you have to figure out what's going on with them. Uremia. Are they clearing the toxins out of their body appropriately? Is it trauma or tumor? Have they hit their head and have a bleed, or do they maybe have a tumor growing and they're putting pressure on things? Is it infection? So a lot of this sepsis stuff we already looked at starts out as a meningitis, right? What's the difference between meningitis and encephalitis? What's meningitis and infection of? The covering of the brain and spinal cord. What is encephalitis and infection of? The brain itself. Yeah. So those, of course, cause increased intracranial pressure. Certainly make them not act right. Could be psychological. Have you guys transported any psych pediatric patients? They're out there. Yeah. I mean, we haven't hit the do what? Yeah. Yeah, they will. They will. Just because it's kid doesn't mean they won't love you. We've had out of control issues in the adult world for a long time with, what do we do with these adult psych patients, and they're taking up beds in the ERs and so forth. It's getting bad on the pediatric side too. And if you think there are no beds in the adult world, there's really no peds psych beds anywhere. We're sending a lot of kids to Chattanooga to Moccasin Bend. So these young kids who have issues. Now, some of them have something that the psychologists and psychiatrists call oppositional defiant disorder. Do you know what that is? That's what my parents would have said. I needed my butt busted. Yeah.
I second that motion.
Yeah. Oppositional defiant disorder is these kids are just unruly and they kind of can't be controlled. And you know, we tell these parents, like, we'll go in to give, I've gone in 100 times to give, you know, a PO med. Like, here's your first dose of Tylenol or amoxicillin, and this child is, you know, 2, and the parents say they won't take it. And I think, really? Yeah, I mean, that's the parents' issue. Yeah. Yeah, I said, you know, if you won't make them take this medicine when they're 2, wait till they're 12. So, shock or stroke. Shock we kind of talked about. What about stroke? Do you see strokes in kids?
Mhm.
Yeah, sure you can. They tend to be hemorrhagic strokes, not the occlusive ones you see in your old people. But if it walks like a duck and quacks like a duck, it might be. These kids have facial droop, arm drift, all the things that you would expect in a stroke patient, but it's really hard to get your head around the fact that this 8-year-old is doing some of these things you expect in this 80-year-old. But if they are younger and they have those symptoms, don't let your brain shut it out and say that can't be a stroke, because it usually is. We work very closely with Fort Sanders. We work very closely with UT. We now have our own stroke protocol. If they need to go to a stroke center, we will do those transfers. But if it's a kid with a stroke, bring in a mess. Like I said, it's usually hemorrhagic, and we're able to manage that. If they're older kids and there's some sort of occlusive issue, we usually take them to the lab over at the fort. All right. So, a couple scenarios. Emily. Emily's a 3-year-old who was diagnosed with an ear infection yesterday at her regular doctor. You show up at the local preschool and you find Emily having tonic-clonic seizure activity. So she's got this generalized shaking all over, and it's been going on about 10 minutes per the caregivers. And she has no history of seizures. So right off the bat, what are you thinking about? Febrile seizure. It's probably the first thing that comes to mind. What sort of management things are you going to have to do with her? So if you're getting your stuff off the truck, what do you need to deal with her?
Airway.
Airway. She needs a little oxygen. She needs an IV.
Yeah, try to stop the seizure.
Probably needs an IV and might have to give something to stop the seizures. So on assessment, she has gargling respirations and a dusky appearance. What's your first action?
Background.
You have bag valve mask, suction, oxygen in a nasal airway, IV access and benzos or suction, oxygen in the oral airway. So who wants number 1? Nobody. Who wants number 2? Couple people. Who wants number 3? Who of you don't know? Who wants number 4? None of you have any other votes, because this is your test. I can make you a written one before we go today, or you can participate in this. So, who wants number 1? Okay, one person wants number 1. Who wants number 2? Okay, 3, 4. Okay, your answer is 2, because she's gargling, so we've got to suction her out, or else we don't have a patent airway, right? So you guys you're right on suction. So why the nasal airway versus the oral airway? She probably still has a gag reflex, and you can't use an oral airway in her. So a nasal airway is your best alternative. Really, guys, this is about the only place that we use nasal airways is in seizure kids. Very, very rarely we'll use an NPA in them for anything else, but it's those seizure kids that just need a little airway support. They won't tolerate an oral airway, so you got to use a nasal. How do you measure a nasal airway, an NPA, in children? So, tip of the nose to the tragus of the ear, same way you do in an adult. Okay, goes in the same way. The only thing different about nasal airways in kids is that, or nasal trumpets in kids, you can't use them in kids less than a year. Well, you can, but their airway anatomy is different enough that it's not really gonna buy you anything. Plus, you probably don't have a nasal trumpet that's that small to go in an air that way. So while you complete the appropriate airway interventions, your partner places an IV in Emily's left hand. You start a bolus, 20 mLs per kilo. She continues to have seizure activity. So the answer here may be different because guys may carry something different, and most services are carrying whatever they could get this week because of all the drug shortages we've seen. But generally speaking, what med would you give? What do y'all carry that you would give? Valium? You carry Versed. Do you use intranasal Versed? Yeah. So do you carry both Valium and Versed? Okay. You carry Ativan? No. Okay. Here's the deal with all three of these primary benzos. In the hospital, we're going to use Ativan because Ativan tends to have a lesser respiratory depressant effect on younger children. The problem with Ativan, though, is it has to be refrigerated. So it's not a great, or you have to toss it in 30 days. So it's not a great drug for pre-hospital. Versed is nice because you can give it intranasally, right? Can you give Valium intranasally? No. Yeah, Valium it's because it's mineral based and the molecules are too big. They're not going to cross over the mucous membrane. So Versed is your drug of choice if you're going to go intranasal. If you're going IV or IO, Versed is okay. Valium's probably my first choice. So every single one of these things, unless you're going intranasally, your dose is 0.1 milligrams per kilogram. It's easy to remember. Across the board on benzos, it's 0.1 milligrams per kilogram, IV or IO. So you give this benzo, you notice her respiratory rate and her pulse start to fall. You're about 5 minutes from your destination hospital. So what are your next actions?
All
All of the above. Y'all know that trick about putting a towel roll under their shoulders, keep their airway open. She's going to need some bag valve mask support. And the hospital needs to know that you're doing airway intervention. Does she need to be intubated? If you can bag valve mask her, she doesn't need to be intubated. And the other reason she doesn't need to be intubated is we know what caused this impaired respiratory drive, right? It's going to wear off in 15 or 20 minutes. So why would you tube her? We'll just do bag valve mask support. So she got assisted ventilations for 10 minutes after she showed up in the ED. She was able to control her own airway, admitted for observation, no further seizure activity, and went home the next day. So for those, I'm going to recap this very quickly because a lot of you heard this the other day, but seizures in kids are for a lot of reasons. Febrile illness is number one. It's the number one reason we see seizures in kids. Infections like the meningitis, encephalitis, hypoglycemia, there it is again, check a blood sugar, toxins, some sort of ingestion, trauma, non-compliance with meds. So you guys with kids, have you ever put them to bed and they wake up like 20 pounds heavier and 5 inches taller? Like overnight, it seems like they grow tremendously. Do it. And the pantry's empty, yeah. Sometimes these kids are, they're taking their meds like they're supposed to. The parents are giving them to them, but they go through this huge growth spurt, and all of a sudden the meds aren't enough to hold off their seizure. Or in teenagers, sometimes they won't take the meds. You know, some of these seizure meds cause weight gain, acne, those kind of things, and they won't take them. Shunt malfunctions. Kids with ventricular peritoneal shunts, their shunts either get clogged up or come apart, intracranial pressure goes up, that's an issue. And then what I call teenage girl seizures, emotional stress, anxiety, fatigue. Yeah. Usually what happens here is they have a vasovagal incident, they just pass out, syncopal episode, they get a little hypoxic, and they kind of shake all over from the hypoxia. So, we've really talked about this already, your anticonvulsants. Check a blood sugar. Now, if you show up on a seizure patient right when the seizure's, over right when you walk in the door, or it's been over for a minute or two when you walk in the door, and you check their glucose, what's their glucose gonna be? Actually, it's gonna be high, probably. Here's why. When they have that seizure, does that involve a lot of muscle activity? Requires a lot of energy, right? So as they're having that seizure, their body is gonna pull every bit of glycogen they've got and start dumping glucose in their system. So it's, you just call it a stress reaction. So right after the seizure, their glucose might actually be up. And stress reaction glucose is like 140, maybe 160. It's not gonna be through the roof high, but it's gonna be pretty high. What's the problem? They're gonna burn all that up, right? So you're gonna check a glucose and you're gonna say, oh, this is 140, their glucose is okay. And then 15 minutes later, it's gonna be in the 12. So you've got to continue to check that glucose, because if it's high right after the seizure, it's probably gonna bottom out later. Describe this seizure. So I think I came last spring. Was it last spring, Travis? We did that. Okay. So not too long ago, and talked about seizures, and we talked about myoclonic and infantile spasms and absent seizures and all this. It hasn't been that long since you heard it, but if you saw it, would you remember myoclonic? Probably not. So where I'm going with this is, describe what the seizure looked like. You don't have to say it was myoclonic, it was, it was this. Just say, was it generalized or not? Were they shaking all over, or was it just one extremity? How long did it last? Do we know if there were precipitating factors? So was this kid riding their bike, wrecked their bike and hit their head and then had a seizure, or did they have a seizure and then wreck their bike? Which came first, chicken or the egg? And just say what it looked like. Their right arm, it was just their right arm was shaking and their eyes deviated, to the right. Whatever. Keep it very simple. You don't have to put a label on it, but it's very helpful, not even to the ER staff, but to neurology when they get there, to know what this looked like. All right, medications. Math sucks, right? Yeah. I hate doing math quickly. Everybody's carrying a Broslo? Did the fire guys carry a Broslo? No. Do the fire guys know how to use a Broslo? We'll pull one off a truck. We'll look at those in just a second. So, yeah, I'll come back to that. All right, so let's look at another case. This is Elrod. Elrod is 6 months old. He was diagnosed with RSV yesterday at his doctor. On arrival of EMS, mommy tells you that he has had increased respiratory difficulty and she couldn't wake him up from his nap. So you know that he's pale. He has a respiratory rate of 12. What's your immediate action?
Four.
Three.
Three. Backup mask. So his respiratory rate's 12. He's 6 months old. What's a normal respiratory rate for a 6-month-old? Oh, a lot. About how much?
20, 40.
Oh, more than that. Yeah. Probably like 30, 32. So he's really not breathing very much, right? So if you put him on a non-rebreather, yeah, he's getting more oxygen, but is he breathing it in enough? Yeah, he doesn't have an oxygenation issue so much as he has a ventilation issue. He's not breathing in and out enough. So we need to use a back valve mask on him. With RSV, he might need to be suctioned somewhere along the way, but we've got to start the support. So with this back valve mask, how many breaths a minute do you give a child?
28, 24.
Who wants number 1? Nobody. Who wants number 2? Who wants number 3? Okay. Who wants number 4? This is your answer right here. Think about this. So even though he breathes about 32 times a minute, this is where you want to go. So American Heart says if you have an adult just with a bag valve mask, you're gonna squeeze that bag somewhere between 10 and 12 times a minute, maybe 8 to 12 times a minute. If you have a child, it's 12 to 20. More toward 20 if they're younger, like Elrod. More toward 12 if they're a bigger kid, older school age. So this is what that looks like. You're going to squeeze the bag, squeeze the bag, squeeze the bag. What do we do in reality? Yeah, this, right? We want this baby to breathe. We know they breathe faster anyway, and we are going to town on this. We have adrenaline going, and we're doing it. So if you hyperventilate your patient, if you're squeezing the bag way too many times a minute, and hyperventilating them, what does that do to their blood vessels? They make them constrict. Well, if you make them constrict their blood vessels, what are you limiting? Blood flow, and therefore oxygen to their brain, right? So you're at cross purposes of what you're trying to achieve if you bag them too fast. So 12 to 20 is your rate for kids. While your partner ventilates Elrod, you continue your assessment, you find this heart rate is 36. What's your next step? Chest compressions. Everybody in here ought to know that. Under what rate do we do chest compressions? Less than 60. How many chest compressions on this 6-month-old are you going to do a minute? At least 100. And the new American Heart Guidelines, and this is across the board on your adults and your kids, says at least 100 and not more than 120. If you've done compressions on a patient since we've been doing at least 100, it's an aerobic workout, right? I mean, you're moving. Some people get a little overzealous, and they're compressing even faster. They're going 120. We had a paramedic come to help. He actually came to help teach PALS at Children's, and he was in our sim lab, and he was doing compressions, and he's very fit, and he does marathons and all this, and he was going right at 140. And we said, slow down. But if you think about it, if you're going too fast, you're not allowing that heart time to refill. So you're squeezing it a lot, but you're not allowing time to refill. So you're not pumping things out very effectively. So despite good ventilations and chest compressions, his heart rate remains in the 30s. So you put an IO in. What's your preferred site for IOs in children? Yeah, where in the leg? So everybody do this. Everybody fun. Tibial tuberosity. It's that bump kind of on the inside of your knee. Right below it's that nice flat spot. That's where that eye is going to go, is in that flat spot at a 90-degree angle. Where else, per the manufacturer, because everybody's carrying easy IOs, right? Yeah. Per the manufacturer, where else can you put them? Yep, you can put it in the humeral head, and you can put it in the distal tibia. I don't like this one in children just because the bone's so thin there, you'll go through the backside probably. Humerus would be my second choice in a kid. And you find your site just like you do with an adult, with either their hand over their belly button or under their butt. And if people don't know how to do that and you are an AMT or higher and can put one in, I'll be happy to talk to you about it. So, heart rate's low, put an IO in. What's your first medication? Epi. Which epi? You want this 1 to 10,000 up here, or you want this 1 to 1,000 up here? All right. Of the paramedics, who wants number 1? Who wants 1 to 10,000? Matt and Todd say, okay. Who wants 1 to 1,000? It's this. The only time you use 1 to 1,000 in an arrest, and this has been the case for years, is down the ET tube. So is there any reason to give any med down the ET tube these days? Very rarely. We've got such good IOs, there is no reason to put epi or anything down the ET tube. The absorption, we don't really know how well it's absorbed. So if you've got this easily placed IO, it's always epi 0.101 milligrams per kilogram or 1 to 10,000, and you stick with that. The other way to do this is in milliliters. It's always 0.1 milliliters per kilo. That's the easy math. So, epi 1 to 10,000 comes in this box. Everybody knows the brown box, right? The brown box is ubiquitous. So you got 1 milliliter, or I'm sorry, 1 milligram per 10 milliliters in this box. Elrod, at 6 months old, weighs 8 kilos. How much are we going to give him? What did I tell you? It's 0.01 milligrams per kilogram or 0.1 milliliters per kilo.
0.8. 2.
Okay, we've got multiple answers across the room. This is why math sucks. And this is why we do bad things to children with meds, right? Because people aren't good at this. You're giving 0.8 milliliters. Okay? It's 0.1 milliliters per kilo. He weighs 8 kilos. You're giving 0.8 milliliters. So if you've got 10 milliliters in this box, so any adult patient you would give 10 milliliters to, how many doses for Elrod do you have in this box?
11.
Yeah, at least 10, right? 11 or 12 maybe. So think about this. If you are in an arrest situation, you're a really sick kid, and you're opening these boxes of our resuscitation drugs, if you have a little one, 6 months, a year, even 2 years, and you open more than one box of anything, you've probably made a drug error. Because there are at least 10 doses in here for Elrod, and if you're given more than 10 doses by the time you get to the hospital, you're coming from very far away, or you've done something wrong. What about atropine? Atropine remains part of the pediatric bradycardia algorithm. What's your dose for atropine? Take it.
0.1.
It's a good guess, Matt, because in kids it's usually 1 or 0.1. Atropine's a weird one. Atropine is 0.02 milligrams per kilogram. That's the odd box. So,
0.16. No.
yep. So there's your dose. 0.16. So here's the purple box. So atropine comes in 0.1 milligram per milliliter pre-filled syringe. So how much do we give him?
1.6.
1.6 milliliters. Guys, think about how little that is. 1.6 milliliters. When you're used to giving a whole amp of something to an adult, 1.6, not much. And you need to occasionally, excuse me, look at your meds and think, okay, if I had a 10 kilo kid, keep it simple. If I had a 10 kilo kid, I had a 20 kilo kid, how much of this would I give them? So you can wrap your head around the fact that this is a normal dose. I get it, going from the opposite direction. One of our doctors, Dr. Levarsky, who's now our chief of anesthesia, he used to be one of our ER docs before we went back to school, and he and I went to a code years ago on the floor, and they called a code for this mommy who had passed out. She was rooming in with her baby, and she had passed out, and she was hypoglycemic. So I put a line in her, and he and I both, I swear, pulled our calculators out. And he goes, "We want to call her 100 kilos?" And I said, "Yeah," and we are doing the math to figure out how much D50 to give her. And we kind of halfway through stopped and looked at each other, and I said, "You want to give her an amp?" And he goes, "Yeah, let's give her an amp of D50. So if you work in PD world, it's tough to think about giving a whole amp of something. If you work in the adult world, which you guys do, getting that visual on what a normal Peds dose is important. So we've had 4 minutes of ventilations and chest compressions, 1 dose of epi. His heart rate goes up to 100. So if his heart rate's now 100, can you stop those chest compressions? Yes. You decided to give him a fluid bolus. He weighs 8 kilos. How much fluid do you give him? 160 milliliters. Other interventions that would be appropriate. So he has RSV. Could you give him an albuterol? Would that be helpful?
You give him 6, call it number 3.
Okay. So let's walk through here. You are correct. Could you give him albuterol? Would that be helpful?
Yeah.
Yep, absolutely. Because RSV, bronchiolitis, is an upper part of the lower airway. Albuterol works down here. Humidified oxygen, absolutely. They'll thin out those secretions. Does he need to be intubated?
Nope.
Nope. Suction. All the above. So if you get humidified oxygen, be an honorary breather, frequent suctioning, shut up safely at the ER with a heart rate of 120, respiratory rate of 32. So, we are drawing close to done. Bear with me for another 5 or 10 minutes. We'll take a break. Vaccines. We don't ask about vaccines in EMS very often. You know, in every ER, it's right there on the checklist, or are your shots up to date? We don't really ask that in pre-hospital. Some things, though, we need to think a little bit more about. Pertussis is running rampant through the pediatric population. What's the other name for pertussis? What's a common name for pertussis? Whooping cough. And these kids, they do kind of whoop. They make this distinctive airway sound, and they will cough, the laryngospasm, and they will cough until they turn purple. And, you know, I've seen older kids do it, and they're miserable, but they're able to get their breath. But if you're 1 and you have a tiny airway anyway, that's a big deal. So pertussis is very common. And just, you know, for your information, pertussis immunity wanes after about 10 years. So if you haven't had a booster shot, and we're seeing more of this in the community, you don't want to get a booster shot. Because I got pertussis a few years ago, probably from one of our patients, and it was just miserable. I mean, for weeks, all I did was cough. Haemophilus influenza type B. You guys with kids know that they get the Hib vaccine. Haemophilus influenza type B is the #1 cause of epiglottitis in children. So if you pick up a child and, you know, epiglottitis, we don't see it very often anymore because the Hib vaccine came out in the early 90s, and most kids don't really get it anymore. But if they have those symptoms of epiglottitis, like they have inspiratory stridor, they look really sick, you know, they're pale, they're mottled, they're tripoding, they may be drooling, they're not able to speak to you. You know, Croupers look pretty good. Their stats are pretty good, they're pink or pale pink. They sound horrible, but they look okay. Epiglottitis, they look awful. If you see that, one of the first questions I'd ask the parents is, are their shots cut up? Because if they're not, you're really worried about epiglottitis. What's your treatment for epiglottitis in the field? Diesel. Nothing. Don't upset them. Don't do anything to them. If they don't like you taking vital signs, don't take vital signs. And I'm saying that in front of everyone in this room who would do QI, but I know we want to fill out all the blanks on our charts, but seriously, if these kids don't, if it upsets them, don't do it. I mean, you can watch them and maybe get a rate. Might be able to get a heart rate, but don't upset them. Meningitis, pneumonia, all those are caused by Haemophilus influenza type B. And then the meningococcal vaccine. Have you guys seen that ad for this on TV over the past few years? It's pretty dramatic. They have a kid on a swing, and they say, this is your child at noon, and then they have a picture of a child on a morgue slab with a toe tag, and says, this is your child at midnight. So the stuff we looked at earlier on with the Tikia and Purpura, and I talked to you about how quickly it's progressive, that's what they're worried about. And there is a vaccine out there for that. Flu season. It's not swine flu this year. Yeah, not swine flu this year, but yeah. Flu season is upon us. Dennis and I were talking before class. We're having a little lull right now. Like we usually this time of year are seeing about 300, 320 kids a day. Our summer census is more like 160 to 200, and we're seeing that 160 to 200 right now.
So it's on the county.
I'm afraid the storm's coming. And the epidemiologists are saying, we've seen this, I mean, we saw flu early. We saw it October, November, then it kind of declined. Now it's coming back. The other thing we're seeing a ton of this year in kids is pneumonia. Like from September, October till now, I mean, we've seen tons of pneumonia. So those are kind of two big things to watch for until we kind of get out of respiratory season.
Angie, have you seen it, like a child presents looking like the flu, smells like the flu, walks like the flu, the test comes back negative?
Yes.
We're getting a lot of that.
Well, just like the flu shot, you know, every year when they decide what they're going to vaccinate against, they have to decide what kind of flu it is, and it's a guess. It's just the best guess, because there are hundreds of types of flu out there. So what we're testing for covers most types, but not all types. So I think the rate of false negatives is pretty high. So if it looks like the flu, we're treating it like the flu.
We'll treat it like the flu, but our numbers don't reflect the number of flu cases.
Yeah. Well, excuse the stats, and that upsets some people, but from a clinical end of, I know, there are people who like the stats, but from a clinical end, we just treat it. And if you think about it, I guess it's been 4 or 5 years, maybe longer now, when we had that big flu epidemic. Le Bonheur in Memphis, Le Bonheur Children's Hospital in Memphis was seeing 800 children a day.
Good.
Yeah. And we jumped up close to 400. But Le Bonheur set up a tent in their parking lot, and they had drive-through flu. And the people would drive up with their child. They would take a set of vital signs, ask about symptoms, and hand them a flu script. And they were gone. I mean, it was a 5-minute process getting through. So if you had flu symptoms, you went through the tent. So it doesn't, it's nice if you can confirm it, but it doesn't really matter. We're going to treat the symptoms. Prevention and preparation, that's what you guys are doing. Like I said in the beginning, we don't see kids a lot in pre-hospital, and people are uncomfortable with it. And, you know, as we've gone through some of these questions, I've seen a lot of blank looks around the room, and I've seen people thinking about stuff you probably ought to know. And it's important because what if it's your kid? I mean, I look around at some folks I work with sometimes and I think, oh, I wouldn't want them treating my child. You know, this is somebody's most precious possession, and you've got to know this stuff because it's a low frequency, high risk event. And yeah, you may get away with never seeing it in your career, but then there's that one time you might. So, you know, treat them like you would want your own child treated, and stay up on the education. And remember that sometimes in pediatrics, your patient is the one holding the child. You know, sometimes there's nothing really wrong with that child. It's psychosocial intervention for the parents. So, any questions? All right, I'm showing that it is 9:30. Mom shall be back at 9:40-ish, and we will start back.
Restrooms are on the 3rd floor. First level. Come on back here.